Good morning, everyone. Thank you so much for joining us today. We're going to give everyone just a second to migrate in from the waiting room. My name is Kate Conroy, and this is the New Jersey Business and Industry Association's Women Business Leaders Council meeting. Thank you so much for joining us. As you make your way in, please go ahead and mute yourself and switch your view from gallery to speaker. If you're not sure how to do that, the team will post some direction into the chat. Quick reminder that this program is being recorded and you all are muted for the duration. To kick things off, I'm going to pass it on to one of our council leaders, Sally Jo O'Brien. Hello, Sally.
Hello, let me unmute myself 1 second. Hi, everybody. Whoops. Okay,
good.
Okay, great. Good morning and welcome everybody. And thank you so much for joining us today. My name is Sally Jo O'Brien. I'm a certified Dare to Lead facilitator, which is the work of Brene Brown, and the director of executive coaching at the Human Emergence Group. And we are so glad that you could make it to this month's Women Business Leaders Council meeting. And again, just want to remind you that we're recording the program and give a big shout out to my fellow co-chairs for 2023, Bradia Chambers, who's founder and CEO of Epic Transformation, and Lorena Mosquera, who is the workflow strategist of Paradigm Marketing and Design, and Stephanie Staub, Director of Infrastructure and Energy, Strategy and Workforce Partnership at the New Jersey Community Colleges. And I'd also like to thank our sustaining partner, New Jersey Manufacturers Insurance Group, our business roundtable partners, CGI and New Jersey Community Colleges Consortium, our presenting partners, which are PSE&G, and our platinum partner, Prime Point, HRMS, and Payroll. And lastly, our event partners, Association Member Trust, Focus New Jersey, and New Jersey Business Magazine. We're going to incorporate some network into the event today so that you make sure to take advantage of that time available a little later in the program. And now I would like to toss the baton back to NJPA and Kate.
Hi, thank you again. We at NJPA are thrilled that this group continues to grow and thrive under the leadership of such amazing women. For those of you who are new to NJPA, we are the largest statewide business association in the country, representing approximately 1 million jobs in the state of New Jersey, which amounts to about 1/4 of New Jersey's workforce. We offer customer development opportunities, visibility through events, magazine ads, or our podcasts and TV shows, and money-saving discounts on stuff you're probably already paying for, like payroll, healthcare, a 401k solution, and HR support. If you're interested in more info on us, I'll drop the website into the chat along with my contact info. Feel free to be in touch and we can get you whatever you need. And an FYI, we have created a Women Business Leaders Council group on LinkedIn. I'll drop a link for that into the chat as well, and hopefully we will that will be a place for us to learn and grow and continue to network. And this is not in the script, but I wanted to just do a quick shout out. We have officially started to market our largest event of the year, the Women Business Leaders Forum. It's going to be in Newark this September, and the feedback has already been incredible. So I will also drop a link for that. I am Kate Conroy, and that's all for me, and I will now toss it back to the fabulous Sally Jo.
Awesome. So now it is my pleasure to introduce our speaker for today, Dr. Debra Koss. Dr. Koss is a board-certified child and adolescent psychiatrist with more than 25 years of clinical experience, and she's a clinical assistant professor with the Department of Psychiatry at Rutgers Robert Wood Johnson Medical School in Piscataway, New Jersey. And through her private practice in Sparta, she has provided mental health evaluation and treatment for children and families in Sussex County, consulted to local schools, and collaborated with pediatricians. And Dr. Koss is a distinguished fellow of the American Academy of Child and Adolescent Psychiatry and a distinguished fellow of the American Psychiatric Association. Take it away, Dr. Koss. Welcome. Thank you.
Good morning. Thank you for that introduction and for the opportunity to be with you today. Truly a Excited to be with a group of women leaders, women professionals, and to have an important conversation about children's mental health. I'll take a moment to share my screen. I've organized a PowerPoint to lead us through conversation for the next 30 minutes or so. And then we'll plan to save time for some Q&A, some conversation with you directly. Okay, everyone see the slides okay? Looks good. Okay, very good. Here we go. So I'm with you today with the support of the New Jersey Psychiatric Association. We are serving as subcontractors for the New Jersey Pediatric Psychiatry Collaborative, and in our role have the opportunity to help to raise awareness about the NJPPC in a number of different settings with a number of different groups. And I hope that through the next half hour or so, I'll be able to help you to learn more about the NJPPC as a system of care in New Jersey that allows improved access to children's mental health service, to understand the role of each member of the NJPPC team, learn what services are available through this model, and how specifically families can access the services. We come together with an awareness of a sense of urgency that currently exists in being able to address the challenges that children and teens are facing. Recent events have elevated concerns about anxiety and depression in our children, in our youth. We know that mental illness is common. 1 in 5 kids experience a mental illness significant enough to interfere in their day-to-day life. Fortunately, we've got a robust research base that helps us both with diagnosis and with treatment. We know that a comprehensive evaluation will allow for accurate diagnosis, and we know that we have safe and effective treatments for the common mental health issues that children struggle with, including various forms of talk therapy, family therapy, medication, and school-based interventions. Early intervention is key. Half of all lifetime cases of mental illness begin by the age of 14. And during this critical time of development, the brain is going through tremendous change. The earlier we can intervene with treatment, the more likely we are not only to address current symptoms, but to really change the long-term outcome for children in a positive way. Unfortunately, there are a number of barriers to care. Families continue to experience stigma, myths and misconceptions regarding mental illness. Insurance companies are not yet held accountable to mental health parity laws, which would ensure that mental health conditions are treated the same way that all medical and surgical conditions are treated. We know that there are shortages of child-trained mental health professionals across all of the disciplines. There simply aren't enough mental health professionals to keep up with the current demand. And we hear about transportation issues, more relevant in certain portions of the state where there may not be the same infrastructure or where greater drive time is required to get to specialty care. And there are other groups of children that are underserved that experience additional burden of these health issues and also additional barriers to care. Today, we have greater awareness of marginalized communities, including our children of color and children from LGBT communities, as just a couple of examples. When access to care is delayed, children suffer the consequences, and we hear from families all the time about the delays. Research tells us that there's an average delay of about 8 to 10 years from the time of first symptom onset to the time of treatment intervention. 1 in 4 parents will report that it's difficult to find specialized care. And ultimately, nearly 80% of youth who are diagnosed do not receive treatment. All of this results in negative outcomes. But I'm here today to focus with you on a solution, and that is improving access to mental health treatment through collaborative partnerships that currently exist between pediatricians, mental health clinicians, and child and adolescent psychiatrists. And the NJPPC provides the infrastructure and the resources that are necessary for these successful collaborative partnerships. So let's get into the weeds a bit and let's talk more about the details of the NJPPC model. It is a regionalized system of psychiatric and behavioral health consultation teams that exist to assist pediatricians in managing their patients' mental health needs. The services through the NJPPC are available for all children up to age 18 years of age or older if children are still under the pediatrician's care. We know that some pediatric practices transition their children at age 18 to adult internal medicine specialists or family practice providers, but some pediatric practices will extend that to age 21. The NJPPC services are free if your child's pediatrician is enrolled in the system. The NJPPC educates pediatricians about children's mental health issues and teaches them how to screen for mental health concerns. With these resources, participating pediatricians can then consult with the NJPPC child and adolescent psychiatrist and other members of the behavioral health system. They can refer patients to the NJPPC staff for intake and referral to community providers. And they also have the ability to access a one-time evaluation of their patients by a child and adolescent psychiatrist, this generally occurring through telehealth. I'll go through this information using several other formats to better illustrate how the model works. But first, let me highlight that there are a number of advantages to treatment through this model. First, we know that nearly every child in the state has a pediatrician, and families have a high level of trust for their pediatrician, generally relationships forming from time of birth or early in child development. And the pediatrician has a great deal of familiarity with both the child and family's history. Pediatricians are generally located in community. Families are not having to travel great distance to access pediatric care. And many families will describe experiencing less stigma in a typical primary care setting. The resources that are available through the NJPPC can also be accessed in a timely fashion. Families are generally meeting with or speaking with a clinical navigator within 1 to 2 days. And if evaluation by a child psychiatrist is needed, meeting with the child psychiatrist within a couple of weeks. The team also works with the family to ensure that they have a strong connection, that they make a connection with referrals to community mental health providers. So the state has actually been divided into 9 regional hubs, and you see the color codes here. Take a moment to find your location, to match your area. I'm here in Sussex County, so pink, the pink region of the state, is serviced through the Atlantic Hub. And you can do that for each of your communities through the state. I want to shout out to all of the partners who are involved in not only the development of this model, but in the day-to-day implementation of all of the services. For those of you with a smartphone right now, I encourage you to take a screenshot of the QR code here. This will take you to a landing page on the NJPA's website that contains this graphic as well as additional information about the NJPPC model. Not to worry if you don't have your smartphone handy with you right now. There's another way of accessing this information revealed later in the PowerPoint. The NJPPC really supports a team-based model of care, and the team exists to provide care and services to the patient and to the family. The primary treatment relationship exists between the pediatrician and the patient, and all the resources that are provided by the clinical navigator and the child psychiatrist are put into place to support this treatment relationship. Each hub has an NJPPC team that is a clinical navigator and a child and adolescent psychiatrist to provide care and services for all of the pediatricians in their region who are enrolled in the program. The clinical navigator is generally a social worker who brings a tremendous amount of experience and expertise to the pediatrician and to the patient and family. The clinical navigator will serve as a point of reference for the pediatrician who may call with questions about what types of mental health resources are available in the community, and will work directly with all families who are referred to make those connections. The child and adolescent psychiatrist and clinical navigator work together to review all the referrals that come into the system and to make recommendations or make decisions pertaining to treatment planning. The child and adolescent psychiatrist is available for telephone consultation to the pediatrician, and as mentioned, can provide a one-time evaluation of the child. The goal being, again, to refer back to the pediatrician when appropriate. If it's determined that more specialized care is needed, then the child is referred out to a clinician with the assistance of the clinical navigator and the child and adolescent psychiatrist. Since the inception of the program in 2015, more than 18,000 children across the state of New Jersey have been referred, and 655 pediatric providers have been recruited, have been enrolled in the model. Behavioral health treatment consultation is the most common reason for referral. You'll see more than 70% of the children referred have been referred with questions about treatment planning. The pediatricians have described a great sense of confidence and competence in their ability to screen and treat children's mental health issues. More than 83% have reported improved skills. And we see that some children are evaluated directly by the child and adolescent psychiatrists. Referenced here, almost 14% or 445 children have been directly evaluated. Let's now walk through the process step by step, and we'll start in the pediatrician's office and then we'll move to the hub. The patient first presents to the pediatrician's office either for an annual visit, a well visit, or a specific sick visit that has been scheduled because of a primary concern around a mental health issue. In either situation, the team at the pediatrician's office will present a screening instrument or a questionnaire to the patient and to the parent, and will ask that that questionnaire be filled out. The pediatrician then goes through the typical steps of examining the patient, meeting with the parents, and now for pediatricians who are enrolled in this NJPPC model will have an additional piece of data that they can put into their evaluation, and that is the results of the screening instruments. The mental health screening consists of evidence-based questions, standardized questionnaires that have been developed specifically to screen for mental health disorders. There are a number of different instruments that pediatricians learn about, and they make a decision about which are most appropriate given the age and stage of the child as well as the presenting complaint. There are both primary and secondary instruments that they can use. And the screening tools generally ask questions about the child's mood, thoughts, and behavior. The screening instrument exists as the first in a series of steps that provides the pediatrician with information and then prompts further comprehensive conversation around those concerns around mood, thought, or behavior. So a screening instrument is not diagnostic. It's not the same as an X-ray, let's say, but it's a critical part of the assessment. Everyone in the pediatrician's office, from front desk staff to back office staff, are informed and aware of the importance of screening. Some pediatricians' practice have trained their front desk staff to share screening instruments with patients and parents, while other pediatricians' offices have trained their nurses and medical assistants to give these questionnaires to patients once they're back in the exam room. The nurse or the medical assistant ultimately will collect the screening instrument and score it and provide the results to the pediatrician. The pediatrician reviews the results and discusses the results with the patient and the family, and when appropriate, will discuss referral to the NJPPC. So anytime a mental health concern is identified by any member of the team using either the screening instrument, the parent's input, the patient's input, or the pediatrician's evaluation, anytime a mental health concern is identified, a referral to the NJPPC can be triggered. And so now we'll talk about that referral process. The pediatrician will describe the NJPPC system to the patient and the family when they're in the office, and will describe the range of services and the team members who are involved, much in the way that I've talked with you about that today. Pediatrician obtains a consent from the parents to refer the patient to the NJPPC and informs the family that the clinical navigator from the hub will be contacting them to gather more information. The pediatrician schedules a follow-up with the family, generally about 2 weeks out, sharing with the family that they will want to follow up on any recommendations that the hub team makes. And ultimately, the pediatrician completes a form with relevant information and sends that off to the hub. Let's shift our focus to the hub. Again, one of those 9 brick and mortar offices that we identified in the state map. The clinical navigator and the child psychiatrist are located at the hub. The clinical navigator is the first to receive and review the referral form. The clinical navigator then contacts the family and gathers additional information about the patient's symptoms, previous treatment efforts, matters of insurance, and with that additional information, reviews all of this with the child and adolescent psychiatrist. The two come up with a list of recommendations, and ultimately the clinical navigator works with the family to make those referrals to community mental health providers. The clinical navigator will work with the family to contact therapists in the community, for instance, and stay with the family until that connection is made, overcoming any barriers around wait lists, lack of appointments, challenges with insurance. When the process of referral is complete, the clinical navigator will then send a letter back to the pediatrician with a list of those recommendations and any other resources that may be helpful to the pediatrician and the family as they continue to address the concerns. The child and adolescent psychiatrist is a physician who specializes in children's mental health, and the child and adolescent psychiatrist serves in a number of different roles. First, the child psychiatrist is available for curbside consultation with the pediatrician. That is, the pediatrician can call the child psychiatrist at any point to ask general questions about children's mental health. It might be a question clarifying how to administer or interpret a screening instrument. It might be a general question, how does depression present in an 8-year-old, or what medication might I consider for a teenager with anxiety? In this type of conversation, there's no protected health information that is shared. These are general learning questions. The child psychiatrist is also available for systematic case review, as mentioned, meeting regularly with the clinical navigator, reviewing all those referral forms that come in, and brainstorming about treatment recommendations. When indicated, the child psychiatrist will give a one-time evaluation of the child. This is infrequent, but it's appropriate at times for children who are presenting with more complex sets of symptoms. This evaluation is generally conducted via telehealth, and the child psychiatrist then determines if the patient can be referred back to the pediatrician. If so, gives guidance to the pediatrician as to how to initiate treatment, or may determine that more specialized care is needed, and in this case will help to refer the family to a child psychiatrist in their community. Finally, the child psychiatrist serves a role in providing education to all members of the team, really making sure that everyone has access to up-to-date research information, high standard of care for children's mental health, and provides leadership to all team members, addressing any challenges, hiccups, or problems that might come up. So just to drive home the point, the team of providers center around the patient, the child and their family, and there are a number of individuals who are involved. Whenever possible, primary treatment responsibility rests with the pediatrician, but there are other members involved, including the NJPPC Child and Adolescent Psychiatrist, a clinician in the community, such as a social worker or a psychologist, who may provide individual therapy or family therapy or parent coaching, a child and adolescent psychiatrist in the community who may take over assessment and treatment and medication management for kids with more complex illness, or any member of the mental health treatment team along the continuum of care, thinking about emergency or higher level services. One final way of driving home examples of how the team works, and that is to talk about a hypothetical student. A 10-year-old girl presents for an evaluation of nonspecific stomach aches and headaches. A parent brings the child to the pediatrician, not sure what's causing these stomach aches and headaches. Pediatrician goes through a typical evaluation process and ultimately discovers that the physical exam is normal. This pediatrician is enrolled in the NJPPC and so has access to the screening surveys that were completed by both the parent and the child while they were in the waiting room. And these screening instruments reveal a number of concerns about anxious and depressed mood. And so with this information, pediatricians able to engage in a lengthier conversation about these symptoms, gathering more information about the child's early history, and as well as any family history around anxiety or depression. Pediatrician learns that the child has a history of separation anxiety going all the way back to kindergarten. And more recently, the patient has again been reluctant to attend school. Monday mornings are especially tough. And the child's also been reluctant to go to friends' homes. Previously had been visiting with friends and spending time with friends, but now reluctant to leave home. The child confides in the pediatrician that she's afraid that something's bad's going to happen to her family whenever she's away from home, and even has difficulty separating within the home. Falling asleep in her own room at night has become really difficult and challenging, and she's regularly co-sleeping with her parent. Pediatrician recognizes through this evaluation that the stomach aches and the headaches are likely a result of the anxiety and the depression, and are a physical manifestation of the stress that the child is experiencing. The pediatrician recognizes that anxiety is a treatable condition and that cognitive behavior therapy and medication can really be effective for 10-year-old children, but not exactly sure about how best to get started and what resources are available in this family's community. And so the pediatrician asked the family, "I'd like to recommend you to the NJPPC," reviews the list of services that would be available, and with the parents' permission, makes that referral and begins to assemble a set of treatment recommendations with the help of the clinical navigator and the child and adolescent psychiatrist. I hope that this information is helpful to you as parents, as family members, and as leaders within your community. I hope that you'll join with me in helping to spread this information far and wide. We've got lots of data now to reflect that this model really does help to improve access to care at a critical time in kids' development. But not everyone in the community knows about this model yet. So here are some ideas about ways to share the information. As family advocates within your own community, you might consider sharing this with members of your school community. School nurses, counselors, child study team members, and teachers are often among the first who recognize that a child is struggling at school. Something has shifted in their behavior, their mood, their performance. And so knowledge about the NJPPC can be helpful to them. There are also other members of school communities. The PTO organizations are critical avenues for sharing resources, sharing ideas about local resources in particular. And then, of course, we know that lots of organizations are generating lists of mental health resources. We've come a long way in recognizing the importance of access to care. I hope that the NJPPC makes its way onto these resource lists. And finally, I'm encouraging all parents to have conversations with their pediatricians about the NJPPC model. We recall from an earlier slide, 655 pediatric providers have been enrolled to date, but there are still pediatric providers out there who don't yet know about the NJPPC or have not yet enrolled. And I think as parent advocates, we can be really persuasive and really compelling in urging our children's pediatricians to join the NJPPC and have access to all these resources. I'll leave you with two other resources for additional information. You'll see here on this slide the actual link to the NJPA landing page, similar to the QR code I shared with you earlier, and contact information for Mr. John Conahan, who is at the Hackensack Meridian Hospital hub and serves as a point of contact for anyone across the state who'd like to learn more about the model, and can also serve as a point of contact or resource if your child's pediatrician would like to speak to someone and learn more about the model. And so with this, I'd like to close with this proverb: if you want to go fast, go alone. If you want to go far, go together. We'll stop sharing and really take the next few minutes to talk with you, to hear about your thoughts or your questions about this model.
Great. Thank you. We're going to open it up to questions right now. And you could either, let's see, I see Pamela's hand up. Go right ahead.
Sure, thank you. Thank you for the presentation. It was really great. I am a former county employee with Monmouth County, and I was the kayak coordinator, Children's Interagency Coordinating Council. And I worked there for almost 6 years and have never heard of you, and have a great relationship with Hackensack Meridian. So I want to know, because I always schedule people to come and speak at the meetings when I work there, and they also have education partnerships. This is throughout the whole state. Like my position, or my former position, better said, exists in all 21 counties. And we are always talking about the need for psychiatrists. We never have enough, never had enough psychiatrists open to meet with children. So I'm very excited. I actually emailed the new kayak coordinator in Monmouth County to say, have you heard of them? And sent the link. My question is, have you worked with the kayaks? Have you talked to the state? And the Children's Interagency Coordinating Council is part of the larger children's system of care for the state of New Jersey. For those people who, you have no reason, unless you've worked with them or have had to interface with them, you don't really have a reason to know about them. But they have parallel, I shouldn't say parallel, complementary services with the various organizations. And I am sure that they would welcome you to come to meetings all over the state. And every county has a ResourceNet website that's free that you could be on so that people could know more about you. So long loaded, excited question about working with the children's system of care. And if there's any information that I can give you, if you don't already have it, I would absolutely share it, because they need you desperately, I promise.
Pamela, thank you for your work with kayak, with the children's system of care. I am aware of kayak, and through my practice in Sussex County, worked with our kayak team in this region of the state, and really recognize how important the community level services are for children and families at various points in their journey addressing children's mental health issue. You highlight the issue that we've become aware of, and that is, despite the success of the model, not everyone who are connected with children and families know about this resource yet. And so by word of mouth, by ResourceNet, by listservs, by meetings, we want to get the information into the hands of families so that when they're working on behalf of their children to access care, they know of this resource as well. I will share that the clinical navigators and the child psychiatrists are working directly with Perform Care and with all of the services that are available for DCF, so that if it's determined through that referral process that Perform Care or the system of care has a level of care that's needed, the clinical navigator at the hub has personal contact with KAYAK, with FSO, with CMO, with all of the agencies that can provide wraparound services.
I'm sorry, 1 second. FSO is Family Support Organization. CMO is Care Management Organization. When I came in, I knew none of the acronyms.
Thank you.
Zero. And I was Googling all the time.
It's
So,
alphabet
just
soup.
sharing. Yeah.
It's alphabet soup, and we need to spell it out. Thank you. You're
Yeah.
absolutely right. Yes, but happy to make a connection with, and thank you already for sending off the email. If there's anyone that you want to send my way, please do. If I'm not able to help, I've got the connection back to the primary hub to make that connection with someone else. So thank you.
Great. Thank you.
Dr. Koss, you mostly touched on it, but what is the relationship with schools when you and how are they and the school psychiatrist or the school counselor, how receptive or integrated are they in your work?
Great question. So I think that I'll answer in a couple of different ways. First, we recognize the importance of meeting children and families where they're at. That is, meeting them in their community, and meeting them at the point of the journey that they are at and coming to recognize and deal with their mental health challenges. Early intervention is key. We don't want to wait until symptoms progress and a child is at a point of crisis, presenting to an emergency room for care. And so meeting kids where they're at, for me, means meeting them in their pediatrician's office when we're guaranteed to have an annual well visit and can screen for mental health concerns, and meeting them in their school communities where teachers will be the first to say, something's changed in Mary's presentation. I'm not sure what's happened, but her attendance has gone down, her school performance has gone down, she's more withdrawn. And the teacher can then work with the counselors at their school to decide how best to reach out to family, how best to try to provide support for the student. So schools are an important part of this approach as well. I will say that both from my own perspective as a child psychiatrist up here in school in Sussex County and as a member supporting the NJPPC, schools are incredibly interested and responsive to this type of outreach. They want to develop a strong connection with community mental health providers to be able to support children as well. We also know that in the coming year in the state of New Jersey, there's going to be another intervention, New Jersey for Schools approach, to provide additional state resources and state funds to support resources within school communities. Topic for another conversation for another day. But again, I think it's just that growing recognition that we've got to meet kids where they're at.
Thank you. I have one other slightly wacky question, but our family, we own a martial arts school, and in the kids program, we see a lot of issues, and a lot of people bring their children so that they have some, structured time, that's not school time, et cetera. But it made me think, and there are people in the group of school in our art that have programs that are specifically tailored to children with different needs. And I just wondered if this is if it's an inappropriate piece of information to refer to parents to, or like from our perspective, or is that more of a doctor school.
No, I think
I'm not asking this in an articulate way, but
no, I think I understand. I think for me, it brings to mind, it takes a village to raise our children, right? And we know that there are many individuals. As a mom, I'll share with you all, there are many individuals in the lives of my kids who were really played critical roles in their development. There's a music teacher, a sports coach, right? Various individuals who get to know kids and to develop a mentoring relationship with that child and may have important information for the family. I think it's anytime we see a child struggling, it's appropriate to connect with a family member and to offer support, and without getting into a kind of a diagnostic or a prescriptive role, to encourage a family to touch base with their pediatrician and to even reference, now that you know about the NJPPC, that a number of pediatricians in the state address these kinds of behaviors or concerns, and have access to other services in your community to help. So you don't have to be alone, right? A parent might confide in you that a child is having tantrums, and you may see those tantrums in your class, and you can connect with the family and say, pediatricians receive training and know how to talk with families about tantrums. You shouldn't be alone with that. And the NJPPC model, and give it a name, give it a word. And that empowers the family then to ask for that specific support.
Great. Thank you.
That's a great question. Hi, Kate.
Hi. So this is something I've been thinking about for a long time. The country that we live in, the school shootings, and it's just been really hard to watch. And one thing that I can't get out of my mind is, if we collectively have decided that guns are not the problem, if we have decided instead that mental health is the problem, what is the likelihood that we could make mental health or therapy something that is just part of the curriculum, like gym is part of the curriculum, like just some kind of group therapy starting young, so that kids feel comfortable talking about their feelings in a healthy way that offers support for them. Is that just a pipe dream? Is that something that could possibly ever happen?
No, what we've really come to appreciate is that, first of all, mental health is required for overall health, right? We can't just be talking about our kids' physical health and physical growth milestones. We have to be attuned to their mental health as well. And we know that there are many, what we refer to now as determinants of health. There are many traumas and stressors within the community that are leading to mental health or associated with mental health challenges for our kids. It's no surprise that rates of anxiety, depression, and suicide are increasing in our youth in 2023 because of the stressors that kids are now dealing with. And so approaching mental health as a way to promote health within children, within teens, within families is absolutely an important step to take. And we talk about prevention, we talk about primary intervention, where everyone can benefit about learning about stress reduction techniques and mindfulness strategies, and yoga and physical exercise as a way to improve mental health, right? The importance of healthy sleep patterns, the importance of decreased use of electronics and social media. The list goes on. And fortunately, there are many leaders in our state now who are leading these kinds of conversations and challenging us to think about innovative ways to bring these resources to kids and to families. And we are looking at and reviewing legislation in our state that will allow us to direct resources to schools, so that schools can develop evidence-based programs where they're bringing in the experts in the field to develop curriculum, so that all kids are getting exposure to this information, again, way before there's a point of crisis, right?
Right.
Let's expose all kids to the importance of health, and mental health as part of that. Work it into a physical education curriculum or your health curriculum. And again, I think as leaders in your own right, as parent advocates in your own right, I encourage you all to bring these types of ideas to your school communities, whether at a PTO meeting or a school board meeting, but challenge the leaders within your school systems to be really thinking about these issues and accessing the kinds of grants that are now available for innovation within our community. Because we are finally at a point where lawmakers are looking to identify resources within state budgets to prioritize children's mental health. So we want to grab hold of these grants. We want to grab hold of these opportunities to bring these resources to our own backyards, our own communities. I'm curious, by a show of hands, who was aware of the NJPPC prior to this? Was anyone aware of the? Okay, there you go. Thank you for making time for me on your agenda today. Again, you'll have access to the PowerPoint. Feel free to share this within your communities. Let's help to get the word out. Pamela, I see you've posted a comment. There are groups like Conscious Youth Development Services that teach mindfulness, emotional wellness, yoga, and more. They presented the New Jersey Education Association as well as local districts, presented at the Society for Prevention of Teen Suicide summits throughout the state. That's excellent. Also, Project Right Now does expressive writing programs. Wonderful, wonderful.
I have one other question. Is there what I'm noticing in my friend group is that the children in our group who have had issues they're now turning 21, they're adolescents, and that's like this really funky period of time where there's not as many services because they're adults, and just wondering if there's another organization that's linked or supporting the next phase of treatment, so to speak.
It is a tricky time. You're absolutely right. Certainly there's an adult system of care that exists that provides mental health services. But this requires an individual to come willingly to
Exactly.
the table and to ask for support and services. And for those of us who have young adults as part of our family, we recognize that being 21 is all about kind of stepping away from family and say, I can do it on my own, right? It's all about that launch towards independence that means that a lot of young adults are not asking for help or not connecting. So it is a particularly tricky time in this transition. I encourage families who are accessing services for their teens to start talking about that transition way in advance of that 21st birthday. And there are systems in play. I think about our students who are receiving special education services through our school districts. There is a process in place through our child study team where the child study team can help the family to begin to access services before the child graduates high school. And for some kids who are at high risk, even extend special education services beyond 18 to 21 to allow for that transition. So it does take a little bit of that kind of preparedness to be thinking that far ahead and to plan for that transition. I also think about groups that exist that can be of help to families parents and guardians who are struggling with this transition for their young adult children. I think about NAMI, the National Alliance of Mental Illness, and MHA, the Mental Health Association. And both of these organizations exist to provide resources both to individuals who are living with mental health issues, but also to families who provide such an important role of support and access to care. These organizations have individuals who walked the walk and who've been through their own journey and can now talk with families about how to help their young adult kids who may not be willing to accept help or may not be ready to accept help. So NAMI, National Alliance of Mental Illness, exists at the national, state, and county level. And Mental Health of America, again, national, state, and county level chapters. Great parent advocates at those groups that can be helpful. Well, thank you. It's been a pleasure to be here. I really appreciate your thoughtful questions. And stay in touch. You have my contact information. If other questions come up, don't hesitate to reach out.
Thank you so much. So we, at this point in the program, would normally break into breakout rooms for networking, but there are so few of us that we thought it might be fun just to do networking right here. So if you wouldn't mind switching your view back from speaker to gallery, yeah, why don't we go ahead and do some 30-second commercials? How do you feel about that?